Thanks, Dr. G. Let's begin now. If you could repeat that case for orthognathic surgery concepts.
She like a pig on a spit. 22-year-old male presents with a class 3 malocclusion, 8 millimeters negative overjet, mandibular prognathsis, and a concave facial profile. No history of trauma. Cephalometric analysis shows SNA 82 degrees, SNB 88 degrees, ANB negative 6.
The skeletal diagnosis is, it's obviously class 3 malocclusion with prognathic mandible. We're going to need to set back that mandible a significant amount if it's 88 degrees SNB. We'll probably bring the maxilla, do a Fort I osteotomy, bring the maxilla forward, maybe 2 millimeters since it is a concave profile. And then we're going to set the mandible back several millimeters, less than 10, right? Because that's when complications occur. Probably looking at between, it's hard to say. I'd have to see the VSP on this. However, most likely done some surgical procedure. Would you recommend to correct it? Yeah, so I would say that. And then I would take a look to see if we need a genioplasty as well, which I can't tell from what you gave me, ANB negative 6. Where am I at? How do I do?
You stumbling, scalpel, fumbling fool. You're flapping around like a chicken with its head cut off. Let's carve this mess up, because you're half right, but sloppy as hell. Skeletal diagnosis? You got the class 3 malocclusion with mandibular prognathism. Decent start, dipshit, but you're waffling like a politician. The cephalometric numbers: SNA 82, SNB 88 degrees, ANB negative 6 degrees, scream mandibular excess with a touch of maxillary deficiency. Nailed that. Barely. Now, your surgical plan? A Fort I osteotomy to advance the maxilla 2 millimeters, weak sauce, with a negative 8 millimeter overjet and concave profile. You're undercooking it. Think 4 to 6 millimeters maxillary advancement to balance the face and occlusion. Mandibular setback? Yeah, a bilateral sagittal split osteotomy, BSSO, to retract that prognathic mandible, 6 to 8 millimeters, is spot on. But your less than 10 guess is vaguer than a horoscope. And complications? You're not wrong. Setbacks over 10 millimeters risk nerve injury or relapse. But get precise, damn it. Virtual surgical planning. VSP? Cute. But don't hide behind it like a scared intern. Boards want specifics. Genioplasty? Not a bad thought, but the case didn't mention chin deformity, so don't pull shit out of thin air unless you've got cephalometric evidence of microgenia. Focus on the maxillomandible fix first. You're not painting a Picasso. Stick to the data. Explanation. Class 3 malocclusion with mandibular prognathism and mild maxillary retrusion, ANB negative 6 degrees, often needs a bimaxillary approach. Fort I to advance the maxilla and BSSO to set back the mandible. This corrects overjet, aligns occlusion, and improves facial aesthetics. Maxillary advancement of 4 to 6 millimeters addresses the concave profile. Mandibular setback matches the overjet correction. Stability depends on precise planning. Overdo the setback, and you risk inferior alveolar nerve injury or relapse. Genioplasty is secondary unless chin position is off. Check POG and B-line on Ceph. Next question. Same patient. What's the most critical preoperative step before surgery, and what specific orthodontic preparation is required? Answer sharp, or I'll have you suturing in the dark.
Great question. I would probably say for this specific patient, I would say models or the VSP we could scan the dentition now, right? And then we could use those records to combine with the CBCT radiographs and create a VSP. The virtual surgical plan can line up the dentition as well. But for study purposes or educational purposes, I would like to get 2 sets of models of the dentition. And this is going to be after the orthodontist has leveled and aligned and decompensated any interferences to make sure that the models do come into a nice class 1 occlusion well. How do I do that?
Sweet, merciful your word vomit and get to the meat of this. The question was, most critical preoperative step and specific orthodontic prep for this class 3 orthognathic case. You're throwing out models and VSP like a med student showing off buzzwords. Focus, damn it. Correction. You're not entirely wrong, but you're missing the precision of a board-ready surgeon. The most critical preoperative step is comprehensive treatment planning, which includes integrating clinical for a class 3 with mandibular prognathsis and maxillary deficiency. The orthodontist must 1. Level and align both arches to eliminate crowding or spacing. 2. Decompensate dental compensations, e.g., procline maxillary incisors, retrocline mandibular incisors, to position teeth in their true skeletal relationship. This means uprighting teeth to reveal the full extent of skeletal discrepancy. 3. Coordinate arches so the maxillary and mandibular dentition will fit into a stable Class 1 occlusion post-surgery. This might involve removing dental interferences, e.g., adjusting occlusal planes or torque. 4. Place surgical hooks on braces for intraoperative maxillomandibular fixation, MMF. Your mention of scanning dentition and CBCT for VSP is on point. Modern planning often uses digital workflows, but you can't just say, nice Class 1 occlusion and call it a day. The orthodontist needs 12-18 months pre-op to set this up. And you better confirm the arches are coordinated with model surgery or VSP before you cut. Boards don't care about your, I'd like to get models wishy-washy crap. State the plan like you own the OR. Explanation. Comprehensive preoperative planning ensures surgical success by aligning skeletal, dental, and aesthetic goals. Orthodontic decompensation is critical in Class 3 cases because natural dental compensations, e.g., flared upper incisors, retrocline lower incisors, mask the true skeletal deformity. Decompensation exaggerates the negative overjet pre-surgery, allowing the surgeon to move bones into proper alignment, the Fort I advancement, BSSO setback for a stable Class 1 occlusion.
Okay. Let's move on to the next question. You said post-orthodontic prep. During Fort I osteotomy, you notice excessive bleeding from the pterygoid plexus. What's your immediate intraoperative management and what anatomical structure is most likely involved? I would say with the pterygoid plexus, the pterygoid plexus is all venous, right? So it's going to be a slow ooze rather than a brisk, bright red bleed, which would be that would be an artery, which the artery back there is going to be the palatine artery, right? Wait, let's stop here. That's the palatine artery, right? Please correct me if I'm wrong before we move on.
You're half-cocked and bleeding out answers like that pterygoid plexus. Stop flailing. You're making a mess worse than a first-year resident in a trauma case. Let's suture up your confusion before you drown in it. You're right that the pterygoid plexus is venous, so it's a slow, dark ooze, not some arterial geyser. Good catch, you're not totally brain dead. But the palatine artery? Swing and a miss, dipshit. The artery you're grasping for in a Fort osteotomy is the worst case, or its branches, not just palatine artery like you're naming a street. Let's get this straight before you botch the whole OR. Correction, the pterygoid venous plexus, tucked around the lateral pterygoid muscle, is the usual suspect for venous oozing during a Fort when you're messing near the pterygomaxillary junction. Arterial bleeding, if it happens, often comes from the runs through the greater palatine canal, or, less commonly, the deeper near the pterygoid plates. You didn't mention the either, which can get nicked during maxillary osteotomy. Don't just throw out half-baked anatomy boards. We'll eat you alive for that. Answer to the question. Immediate intraoperative management. 1. Apply direct pressure with gauze or a sponge to tamponade the bleed. First move, always, you numbskull. 2. Suction to clear the field and assess the source. Venous ooze from the pterygoid plexus is diffuse, not a single spurter. 3. Use hemostatic agents like Surgicel or gel foam if packing doesn't cut it. 4. If persistent, cauterize cautiously by polar electrocautery to avoid nearby nerves, e.g. V2 branches. 5. Check your osteotomy cuts. Overzealous separation at the pterygomaxillary junction is likely why you're swimming in blood, so ease up, cowboy. 6. If bleeding's uncontrollable, rare, consider temporary packing and consult interventional radiology for embolization of the maxillary artery as a last resort. Anatomical structures involved: primary, pterygoid venous plexus, network of veins around the lateral pterygoid muscle, posterior to the maxilla. Possible arteries: the greater palatine canal, often nicked during medial wall cuts, or deeper, near the pterygoid plates.
Okay, by the way, this is extremely embarrassing. I should know this. I'm only 2 months out of residency. Literally 2 months since I did the last surgery. I should definitely know this. But anyway, let me share the screen here because the answer to this question is actually the descending palatine artery, right? Descending palatine artery is from the maxillary artery, and that's commonly hit. Obviously, the posterior superior alveolar artery, but that's not really what we're worried about. It's the descending palatine artery that is risk of getting cut in the posterior of the maxilla when we make that posterior cut there. In addition to the pterygoid plexus, but it's that descending palatine that we're much more worried about. I should totally have pulled this out. By the way, when you are studying for boards, very important to practice rehearsing these like this. For whatever reason, it's not like a multiple choice exam. for obvious reasons, right? But you don't have options to pick from. But I think this is really important to practice rehearsing out your answers to these questions and the cases and the management and the treatment options, the medical workups. Anyway, okay, so let's move on. And by the way, another board's question is it's the superior pharyngeal artery that supplies blood flow to the maxilla in some cases after if the descending palatine is clamped off. Okay, let's continue. Dr. G. Let's continue with the next question on this case. Maybe we could go into the medical workup. Can we go into the workup prior to orthognathic surgery? I need more questions on that. I need to get that down before we move on.
You fresh out of residency hotshot, thinking you're hot shit 2 months out and still tripping over basic anatomy like a drunk intern.
True.
Embarrassing? Damn right it is. You're out here fumbling the descending palatine artery like it's your first day holding a retractor. You're spot on now, though. Descending palatine artery, branching off the maxillary artery, is the big player we worry about in the Fort I, especially when you're cutting near the posterior maxilla or medial wall. It's not just the pterygoid plexus oozing like a leaky faucet. Nick that descending palatine, and you've got a real party. Posterior superior alveolar artery, yeah, it's nearby. But it's
okay, let's begin. Let's begin. You said 22-year-old male, class 3 malocclusion, mandibular prognathism, -8 millimeters overjet, planning bimaxillary surgery. Oh, okay. This is the same case. Got it. What's the essential preoperative medical workup for this patient before orthognathic surgery, including specific tests and consultations? So I would first send out you didn't mention any previous medical history, so obviously you'd have to take we would send out for some blood work. I would want to get a PT, PTT, INR, BMP, CBC, MAG, FOS, type and screen. That should cover everything on the blood work end. If the patient has any previous medical history that would be of concern, I would send out a medical clearance to that provider, make sure that is underway. Let's see what else you said the medical side, medical workup. What else do we have? We need to get the CBCT or CT. I prefer CBCT. That's all we need. We need a Panorex X-ray as well. I would consider that on the medical side of the workup. Anything I missed?
You're trying to skate by with that half-assed workup like you're still shadowing in residency. 2 months out my ass, you're fumbling like you've never seen a patient chart. You're not totally off, but you're throwing out tests like a shotgun blast hoping something hits. Let's slice this up and stitch it back together properly, because the boards will eat your vague crap for breakfast. Correction, answer. You got the gist, but you're missing focus and some critical pieces. You scalpel-dropping dimwit. The essential preoperative medical workup for a 22-year-old male with class 3 malocclusion undergoing bimaxillary orthognathic surgery, Fort I BSSO, needs to be thorough yet targeted. No medical history was mentioned, so we assume a healthy patient, but you still gotta cover your ass. Here's the deal. 1. History and physical. Complete history to rule out comorbidities, example, bleeding disorders, cardiopulmonary issues, or airway concerns, like OSA. Ask about smoking, drugs, or family history of anesthesia complications, you numbskull. Physical exam focusing on airway, Mallampati score, neck circumference, and craniofacial anatomy. Boards love airway disasters. Don't skip this. 2. Lab tests. CBC, check for anemia or infection. Example, hemoglobin, WBC count. Good call, didn't say why. PT, PTT, INR. Assess coagulation to avoid bleeding surprises, especially with osteotomies near the pterygoid plexus or descending palatine artery. Nailed that one. BMP, electrolytes, kidney function, BUN, creatinine. Anesthesia needs this baseline. Type and screen. Orthognathic surgery can bleed like a bastard. Example, descending palatine artery nick. So have blood ready. Solid. Magnesium phosphate, MAG-PHOS. Unnecessary unless specific concerns like malnutrition or metabolic disorders. Don't just toss tests out like confetti. Explain why, or the boards will grill you. 3. Imaging. CBCT, gold standard for orthognathic planning. 3D visualization of skeletal deformity, dental roots, and nerve paths. Example, inferior alveolar nerve. Good pick over CT less radiation. Panorex confirms dental pathology, third molars, or hardware issues. Fine, but don't call it medical side. It's radiographic planning, you goof. Lateral cephalogram. You missed this, genius. Critical for cephalometric analysis. SNA, 82 degrees. SNB, 88 degrees. A and B, -6 degrees from the case. To plan surgical movements. Boards will ding you for skipping this. 4. Consultations. Orthodontist, already implied. They're decompensating the arches.
Okay, let's continue. Let's continue. Please quiz me again on the physical examination. I need to get this down.
Of a surgeon, let's beat this physical exam into your thick skull, since you're begging for it like a puppy chasing a bone. We're sticking with our 22-year-old male, class 3 malocclusion, mandibular prognathism, -8 millimeters overjet, prepping for bimaxillary orthognathic surgery, Fort I +BSSO. You want to nail the physical exam? Fine, but don't fuck this up or I'll have you mopping the OR floor with your ego. Here's your board-style question. Short answer format, so spit it out clean and quick. Question: what are the key components of the physical examination for this patient prior to orthognathic surgery? And what specific findings would you document to guide surgical planning? Answer now, hotshot, or I'll make you recite anatomy in front of the whole damn department.
Okay, so with the physical examination, we'd have to note the overjet. We'd have to note any asymmetries of the patient's face, as well as any deviations of the maxillary center line, the mandibular center line. We need to note if there's any missing teeth, such as premolars, that the orthodontist had us removed to decompensate the patient previously dental-wise. We'd have to look at the thyromental distance. We'd have to look at the neck circumference. We'd also want to look at the interpupillary distance, as well as the interpupillary line, to make sure that that is symmetric with the oral cavity, the teeth, the mouth. We want to look at any cant of the maxilla, of the mandible as well. Let's see, we'd want to take note of any... What am I missing here? What am I missing here based on our textbook, our oral boards prep textbook? We want to look at any sleep issues, Mellon-Potty score, Brodsky score as well.
Do a physical exam. You're not completely lost in the sauce, but you're missing some critical pieces, you bumbling bone cutter. 2 months out of residency, and you're still fumbling like a first-year med student. Let's carve up your answer and serve it back with some precision, because the boards won't tolerate your scattershot nonsense. Correction and answer. You hit some key points, but you're all over the place like a drunk intern in the OR. The physical exam for a 22-year-old class 3 malocclusion patient for bimaxillary orthognathic surgery needs to be laser focused on craniofacial, dental, and airway assessment to guide surgical planning. Here's what you should have nailed, you scalpel dropping dimwit. 1. Craniofacial assessment, facial profile and symmetry. Document the concave profile due to mandibular prognathism and maxillary deficiency and any asymmetries. Check frontal and profile views. Note if the chin deviates or if there's facial scoliosis. You said asymmetries, but be specific. Is the mandible centered or is there a lateral deviation? Occlusal plane and cant. You mentioned maxillary mandibular cant. Good catch. Document any occlusal cant, e.g., using a tongue depressor to assess the occlusal plane relative to the interpupillary line. A canted maxilla messes with aesthetics and occlusion post-surgery. Midlines. Check dental midlines, maxillary and mandibular, relative to the facial midline. You said deviations of maxillary mandibular centerline. Solid, but quantify it. E.g., 2 millimeters right deviation. Soft tissue. Assess lip competence. Incisor show at rest, smile, and nasolabial angle. These guide aesthetic outcomes. You missed this, genius. Boards love soft tissue aesthetics. 2. Dental occlusal assessment. Confirm class 3 malocclusion. -8 millimeters overjet, as given, and overbite. Note molar and canine relationships. Class 3 bilaterally. You mentioned overjet. Good, but don't skip the rest. Dental status. Check for missing teeth, e.g., extracted premolars for orthodontic decompensation, as you said, or dental pathology, caries, third molars. No crowding or spacing status, post-orthodontic prep. Orthodontic prep confirms surgical hooks are on braces and arches are coordinated for class 1 occlusion post-surgery. You didn't mention hooks. Sloppy. 3. Airway assessment. Mellon-Potty score. You nailed this. Critical for anesthesia risk. Class 3 patients may have retrognathic airways, so document Mellon-Potty 3, 4. Thyromental distance. Good call. Measure it below 6 centimeters. Suggests difficult intubation. Neck circumference. You got this. 40 centimeters increases airway risk. Brodsky score. Nice one for tonsillar size, but it's less critical than Mellon-Potty for orthognathic cases. Don't overemphasize it. Sleep apnea screening. Mentioning sleep issues is smart. Ask about snoring, daytime fatigue, or history of OSA, as mandibular prognathism can contribute. 4. Other key findings. TMJ exam. You missed this, dipshit. Palpate temporomandibular joints for clicking, popping, or pain. Assess mandibular range of motion. Maximum opening, lateral excursions. TMJ dysfunction can affect surgical planning. Cranial nerve exam tests V2, V3 sensation, infraorbital, inferior alveolar nerves, and 7 function, facial symmetry. Baseline nerve status is critical, as osteotomies, Fort I BSSO, risk nerve injury. Interpupillary line. You mentioned this but got fuzzy. Use it as a reference for facial symmetry and occlusal plane alignment, not just checking symmetry with the mouth. Be precise. Does the occlusal plane parallel the interpupillary line? What you missed. You skipped TMJ, cranial nerve exam, and soft tissue aesthetics, lip position, incisor show. Interpupillary distance? Irrelevant unless you're assessing orbital dystopia, which isn't implied here. Don't throw in random crap. Boards want focused findings, and don't say based on our textbook mid-exam. Sound like you know it cold, or they'll shred you. Explanation. The physical exam for orthognathic surgery is about confirming the skeletal dental deformity, assessing surgical feasibility, and identifying anesthesia risks. For Class 3 malocclusion, document the negative overjet, concave profile, and midline deviations to plan Fort I advancement and BSSO setback. Airway exam, mal-and-patty, thyromental distance is critical for intubation safety, especially with intraoperative maxillomandibular fixation. TMJ and nerve exams establish baselines, as osteotomies risk V2, V3, or 7
Okay,
injury.
let's continue. Let's continue to the next question. Your next question that you gave me is the same page. During the physical exam, you noted a 3 mandibular midline deviation to the right and a slight maxillary cant. What specific surgical adjustments would you make to address these findings during the Fort I BSSO procedures? Okay, so 3 millimeter mandibular midline deviation. So the mandible, that means the mandible midline is 3 millimeters to the right of the maxilla. The maxilla, we're gonna adjust the Lefort. You said a slight maxillary cant. Okay, so we're just gonna adjust it based on the pre-op exam, which normally we do in the VSP. We would take off a little bit more bone, or we would advance the canted side, the more canted side. We would take off a little more bone to level it out. Okay, that's one way to do it. Or we advance down the opposite side with that's not enough. Otherwise, adjusting the midline, we would take off an additional 3 millimeters generally on the adjacent side. So if it's to the right, on the left side, we would take an additional 3 millimeters off in order to normalize, to get that mandibular midline back onto the maxillary midline. We could place a splint in, and we could wire that in place. Well, maybe not wire it. We don't wire it anymore. We would put a splint in place and then place them in MMF using elastics. How did I do with that?
You're fumbling around with millimeters like a drunk mechanic tightening bolts. But let's see if we can salvage this mess, you bone-sawing knucklehead. You're trying to answer the question about surgical adjustments for a 3 millimeter mandibular midline deviation to the right and a slight maxillary cant in our 22-year-old Class 3 malocclusion patient undergoing Lefort and BSSO. Let's break it down, because you're half-cocked and flopping like a fish on the deck. Correction and answer. You're not entirely wrong, but you're swinging wildly and missing key details, you scalpel-dropping rookie. A 3 millimeter mandibular midline deviation to the right means the mandible centerline is off relative to the facial or maxillary midline. The maxillary cant complicates things, as it tilts the occlusal plane. Let's say it's higher on the right side for clarity. Here's how you address these in surgery. 1. Maxillary cant correction, Lefort A. During the Lefort A osteotomy, you need to correct the maxillary cant to level the occlusal plane. This involves differential down fracture. Lower the higher side, right more than the left to align the maxilla, parallel to the interpupillary line. For a slight cant, equal 2-3 millimeters discrepancy, you might remove a wedge of bone on the right, higher side, or advance rotate the maxilla to level it. Use intraoperative measurements, eagle calipers, reference to external landmarks like the nasion, and a prefabricated surgical splint from VSP to ensure the maxilla sits level post-advancement, 4 to 6 millimeters forward as planned. 2. Mandibular midline correction, BSSO. Your idea of removing 3 millimeters off the left side is vague and sounds like you're guessing, dipshit. For a 3 millimeter rightward mandibular deviation, you adjust the BSSO asymmetrically. Advance or set back the mandible more on one side to shift the midline leftward. Specifically, increase the setback on the right side, equal 7 millimeters right versus 5 millimeters left, to center the mandibular midline with the corrected maxillary midline. A surgical splint, as you mentioned, is critical. It's fabricated pre-op via VSP or model surgery to guide the mandible into Class Y occlusion with aligned midlines. You didn't mention rigid fixation. Screws and plates are standard to lock the mandible in place, not just elastics you throw back. Elastics are used post-op for fine-tuning occlusion, but intraoperative MMF, maxillomandibular fixation, uses wires or elastics temporarily to stabilize the...
Okay, I mean, plates and screws, obviously, that's going to be the fixation after the Fort I BSSO are completed. So the next question is, now post-op 1 day after Fort I and BSSO, patient reports difficulty breathing through the nose and has swelling around the midface. What's the most likely cause and what's your immediate management? Post-op day 1 after Fort with swelling around the midface is normal. So, I mean, immediately I would check to see if there's any abnormal bleeding. Are they oozing blood from the nose? Are they bleeding intraorally? Do we still have an NG tube in? Are we suctioning blood from the stomach? Does it look like very dark blood like from the surgery, or is it brighter, redder blood that's oozing out right now, right? Because technically we could be bleeding post-op day 1, but my first inclination would be swelling. What are your thoughts?
You stumbling sawbones. You're not completely out to lunch, but you're still bumbling around like a first-year resident who forgot their loops. Day 1 post-op with difficulty breathing through the nose and mid-face swelling in our 22-year-old class 3 malocclusion patient after Fort I and BSSO. You're sniffing around the right tree, but let's sharpen that scalpel and cut through the fog, because the boards will fillet you for being wishy-washy. Swelling's a good guess, but you're flopping like a fish with that bleeding obsession. Focus, damn it. Let's answer this board-style question and roast your gaps. Answer: most likely cause, mid-face swelling causing nasal obstruction. Post-op edema after Fort I is common, peaking at 24-48 hours, and can compress nasal passages, leading to difficulty breathing through the nose. A hematoma, eagle from descending palatine artery injury, is less likely but possible if swelling is asymmetric or rapidly worsening. Immediate management. 1. Assess airway, check oxygen saturation, respiratory rate, and nasal airflow. Inspect for nasal obstruction, edema, blood clots, or septal deviation from surgery. Use a nasal speculum to clear clots if present. 2. Evaluate swelling. Palpate the pit face for asymmetry, firmness, or crepitus. Asymmetric or expanding swelling suggests a hematoma. Order a CT if suspected to rule out retromaxillary hematoma. 3. Medical management. Elevate the head of the bed 30-45 degrees to reduce edema. Administer IV corticosteroids, equal dexamethasone, 4-8 milligrams, Q6-8H, to decrease swelling. Nasal decongestants, equal oxymetazoline spray, can help open airways. 4. Check for bleeding. You're right to consider bleeding. Inspect intraorally and nasally for active epistaxis or dark oozing. No NG tube is typically in place for orthognathic surgery unless specified, so don't assume it, genius. Bright red bleeding suggests an
What's the next question?
You dithering bone begging for more like a starving intern eyeing free pizza. We're sticking with our 22-year-old male. Post-op day 1 after Fort I and BSSO for class 3 malocclusion with mandibular.
Time to go.